So I've been assigned ectoparasitic diseases. I chose this because I've seen some of these cases. So basically, I'm just going to present 5 cases. 4 of them I've seen. 1 was anecdotal, um, and I like to call them the creepy crawlers. And there was this show, or I don't know, toys about this.
Was a boy's equivalent to fake photos.
There you go. Yeah. I probably had one of these. Yeah. You could cook them or something.
Yeah.
Right? Okay. So as a method of introduction, what are ectoparasites to begin with? So they basically are a diverse group of organisms that cause human infestation, and they can be arthropods, nematodes, flies, bedbugs, lice, fleas, mites, and ticks. And Dr. Green already talked about some of them, so this is going to be a way for you to show what you learned. And then the individual organism causes these large skin lesions that can be seen by the unaided eye at a macro level, which is kind of different from what we're used to. That is always micro, and we can't really see. Most of them have in common that they cause intense itching and pruritus. And it doesn't really cause a high mortality, but it's very annoying and causes considerable discomfort to the patients. And in some cases, it can lead to high morbidity. So most of these do not carry disease-causing microorganisms, the ones I'm going to talk about in this presentation. They're the direct cause of disease instead of being a vector for that infectious disease. But there's exceptions, like Dr. Green talked about earlier. The body louse does serve as a vector. Some mites do as well. And ticks, they're also vectors, and I've excluded that for another topic because if not, I wasn't going to finish today. So that'd be something to include maybe in a future lecture series. So basically, this is the agenda. We're going to discuss pediculosis, scabies, bedbugs, myiasis, tungiasis, and cutaneous larva migrans. These first three occur worldwide. You don't necessarily have to be in a tropical or subtropical area to see them, versus myiasis, tungiasis, and cutaneous has a tropical region association to it. And then without further ado, our first case. So this is a 7-year-old healthy Hispanic girl. She's from Puerto Rico. She gets home from school. She's tired. She falls asleep on her mother's lap. Her mother then says that the child was sleeping comfortably. She wasn't asymptomatic, and suddenly she felt a bug crawling on her skin, and she thought she saw it jump from her child's head. So the mother shows the pediatrician and what can I do about it? So this is in summary, a healthy, immunocompetent pediatric patient with a concerned mother who believes that the child is infested by bugs. So what is the likely ectoparasitic etiology? Any educated guesses? Any thoughts? Any interaction from the fellows? Any guesses? Just pick one. There's no wrong answers. Maybe there are. Pediculosis, I heard? Oh, correct. Yes, pediculosis. So pediculosis is just a fancy way to say lice. Okay, so basically we have head lice, body lice, and pubic lice. Head lice, another, the scientific name is Pediculus humanus capsis. Body lice is Pediculus humanus corporis, and pubic lice is Pediculus or Thyris pubis, aka crab louse, because it looks like a crab. So it's fair game for the boards to show you any of these pictures, and kind of you have to visually identify what type of louse it is and what is the clinical syndrome associated to it. So basically, head lice is a infestation of the scalp. It doesn't carry any disease. It can range from asymptomatic to severe pruritus. The pruritus is basically a reaction to the saliva of the louse. That's what causes so much itching. And it most common in school-age children. It can occur worldwide, both developing and industrialized countries. And the way you diagnose this is just by seeing, it's a clinical diagnosis. You see the live organism. And the transmission is more person-to-person, head-to-head contact, more so than fomites, but it can also occur with, just having them in the bedding, clothing, towels, headgear, brushes, combs. And the tidbit of the Hispanic girl from Puerto Rico is not that it's more prevalent in Puerto Rico. I just want to let you know I got lice when I was 7 years old. And that was my full hair, my long hair, and I got cut. pretty traumatic for a girl in kindergarten. So basically, the treatment it relates to their life cycle. So you have an adult louse that lays the eggs that are called the nits, and then the nymph hatches from these eggs. And the first thing you have to do is manually remove all the nits by combing the wet hair. And in some young children, this is the only alternative because some drugs are contraindicated. Most drugs kill the adults and not the eggs, so their cure rate is about 75 to 98%. And this is the rationale why you retreat these patients within a 7 to 10-day period so that you can kill the nymph as they hatch before they, lay more eggs. So because then it's just kind of an ongoing infestation. Okay, so finding nits without lice doesn't mean infection. Basically, think of it as a hatched egg that doesn't have anything inside. So some nits can remain visible after you do the live lice eradication, but then the child can return to school after the first topical treatment. And this is how the nits like to be on the hair shaft, so that's how it looks. And then to the unaided eye, this white kind of little egg on the hair. So this is a busy slide, but this is a good kind of summary table on the treatment this is from the Mandel. I'm pretty sure I got treated with this thing called matapiojos, which is the Spanish translation for kills lice. So I'm not sure what that had, but basically it probably had. So the first line, what is the correct answer in the board is pyrethrin or permethrin, okay? Pyrethrin is a chrysanthemum extract, and permethrin is a synthetic drug derived from that extract. And it's over the counter. It's what you call RID, NICS. There is increasing drug resistance to this, but it's still the first line, okay? And the only time you would not use this is that the patient had a prior allergic reaction. You have to consider an alternative regimen. Other agents that are used, malathion is also used, but it's malodorous. Malathion malodorous. So a lot of people don't comply with the retreatment, and it's flammable. So if you would apply this and then you do a curling iron, a blow dryer, you get to catch fire. So not very safe, right? And then linzane is not a correct answer anymore as well, because it is associated with CNS toxicity, especially if the patient has pre-existing seizure disorder. So, and then alternative regimens that you can probably find listed in the Sanford guide is ivermectin. You have oral and PO versions, and then, but you can't use that in pregnancy or young children. So things to consider because this is fair game for the board. And then there is some combination that you can do Bactrim and permethrin as well, but the right answer is permethrin, okay, or pyrethrin. And body lice is basically something that Dr. Green also talked about. It's severe pruritus, hyperpigmented excoriations, most commonly, as Dr. Green said, immunocompromised, homeless, indigent, poor hygiene, sharing a bed. You just see the lice. The lice leave the clothing for the blood meals. So just by destroying or treating the clothing, you're gonna get that delousing done. And person-to-person contact more than fomites and permethrin with the alternative of ivermectin. And this slide I'm not going to go over a lot because I think Dr. Green covered a lot of it. But basically, these are the bacterial diseases that can be transmitted with body louse as a vector. So that it's the same slide that it's just those three entities with the Brill-Zinsser disease of relapsing after. And the treatment for all of these is doxycycline. There are lookup questions. There are different duration. You can adjunct for the Bartonella, but delousing as well for the louse-borne version of it is also very important. And then pubic lice, this can also spread to the eyelashes, and it's called Pediculosis ciliaris. The transmission of this is sexually transmitted. So it is common to find concomitant STDs when you identify somebody with pubic lice or crabs, and you have to test for everything else at the time of diagnosis: HIV, syphilis, chlamydia, gonorrhea, and you have to treat sexual contacts the last 30 days. And then again, lice net removal and the permethrin cream or perithrin to all areas affected, which could be the pubic area, perianal area, thighs, trunk, axilla, and you have to retreat at 7 days. And then for the eyelash one, you have to do petrolatum jelly, Vaseline, or some type of ophthalmic ointment twice a day for about 8 to 10 days, and then you can remove the lice. Okay, because there's nothing really topical treatment that targets the lice for in that sense. And if there's treatment failure, you do ivermectin and you repeat in 2 weeks. Okay. And then this is the differential diagnosis that is associated to this. It could be dermatitis, whether it be eczematous or seborrheic, lichen simplex chronicus, folliculitis, tinea, scabies. So things to keep in mind with similar presentation. On the prevention, they do not survive outside of the scalp or body for more than 24 hours. So you just have to sanitize the environment, remove all human reservoirs, meaning like when I got my lice, I didn't go to school, so that's a method of control. You have to clean everything, the headgear, the hats, scarves, combs. You have to hot cycle wash and dry heat. And then if you can't wash or dry anything, you have to place that in a sealed plastic bag. And that is how you prevent from it spreading to others. So yeah, next case is this was actually a patient I saw at the VA. This is a 42-year-old male veteran. He contacted his primary care, which was me at the time, and he had this new genital rash, areas of involvement, penis, groin, thighs, and he described his skin lesions as very itchy, fluid-filled. And he last got tested for STIs 3 months ago, and he wanted to be rescreened for STIs. So the first thing I thought is, maybe this is an STI, and what is he doing that he wants to be rescreened? So the first thing is sexual history. So the CDC gives us a nice mnemonic called the 5 Ps so that you can remember what is pertinent to us in the sexual history. So partners, practices, protection, past history, prevention of pregnancy. So I always want to know, do you have single partners or multiple? Is it a male, female, transgender, both? We try to be as inclusive as possible. What are your practices? Are you involved in sex work or IV drug use? Are you male who have sex with male? Do you use condoms? Have you ever been treated for an STI in the past? Or do you have any context of STIs? And what are your, contraceptive plans and all that? So this was a non-HIV. He was immunocompetent. He was a cisgender male. He was a male who had sex with women, monogamous. He had a wife. She was HIV negative. She was a cisgender female. He said, I don't have all other sexual partners. I don't practice extramarital relations. I don't think she does either. And then he didn't have any history of anal receptive, and he was recently treated for syphilis by me. And then I was thinking, well, maybe this is, maybe a genital herpes outbreak. By the way, he described it, and he didn't have a condom, and he had an 8-year-old son with his wife. So, by the way, I wanted to do a little disclaimer here. We usually don't test the HSV 1 and 2 serology because they don't correlate with active disease. So when I'm testing people for STIs, I don't order this, but my nurse, my pack nurse, he would order it, and I had a couple of talks with him about it. But basically, he was treated for syphilis with 3 penicillin weekly, and he didn't have chlamydia, gonorrhea, or HIV. He possibly had a prior exposure to HSV2 again. I don't use that to diagnose active disease. It's a clinical diagnosis anyways. And so I thought, maybe let's treat him for a herpes outbreak. Let's see if that's it. So then he wrote to me the next day, obviously, because they take 1 pill and they think, yeah, I'm going to be cured the next day. So he said, I got the medication and I started taking it and it helped the itching, but then it got worse. And then he said he was concerned about syphilis because apparently his wife didn't go for the testing or the treatment, so he thought maybe, he got reinfected. But then he said that the bumps were going down his legs and spreading to his hands, and they were really pruritic and they popped and leaked fluid, and he was using cortisone. I'm like, what's going on here? It wasn't like nothing was fitting for me. So I consulted the dermatologist. This is not what you do on the boards, by the way. You don't refer. You have to figure it out yourself. I had, at that time, teledermatology is a cool feature of the VA. You send the picture in, they take a picture of the rash, and they send it electronically to a dermatologist, and they give you what they think it is. And if they're kind of stumped too, they bring them in for a face-to-face visit. So at this time, it was the pandemic, so they were kind of limiting face-to-face. So this was even more helpful because I sent the pictures via encrypted email to the dermatologist. And just to add, and I said, oh no, they're going to cancel his surgery if I don't get this taken care of. They did cancel his surgery. And then, so this is basically an immunocompetent patient with an intensely pruritic rash involving genitalia, groin, now spreading to the thighs, legs, feet, hand, and it turned out to be an ectoparasitic disease. So which one do you guys kind of think? Scabies. Yes, I heard scabies. Very good. So this was a scabies case. And then this is what dermatology wrote, and I gotta give it to them, props to them. They wrote scabies on there. So I was happy that they helped me figure it out. And then the patient the next day, he said, my son went to his primary care doctor and was told he had scabies. He has the same thing going on as me, and he's 8 years old. So listen to your patients. They're going to tell you the diagnosis. In this case, pediatrician did not miss the diagnosis as I did. And basically, we treated him with Permethrin, and we did the retreatment as well. And he actually got a skin biopsy from the derm, and the skin biopsy said eczema versus cutate psoriasis. And then the dermatologist said, okay, this does not make any sense. This does not clinically correlate. His responding to the Permethrin, so he's got scabies. So his surgery got canceled, never got rescheduled anyways. And interesting update, and this is the beauty of outpatient primary care and outpatient infectious disease, is that a year later, I asked him, hey, how are you doing? Scabies resolved. And he's like, oh, I'm a little depressed. And I said, why? And he's like, I got separated from my wife. Apparently she was doing some sex work. He didn't know about it. So I always wonder, who brought the scabies to the house? Was it her? Was it the kid? Who? So I'll never know, but interesting tidbit there. Exactly. It did not. That's why I was so stumped. It didn't look like traditional scabies, like the classic burrows. So that's why I got the dermatologist, and he actually got a skin biopsy. So when you're stumped and it's an atypical scabies, a skin biopsy is indicated.
Actions that look like you get like perfectly contracted and there's something for like different variations of scabies with certain forms of scabies look a certain way, or
yeah, and I have a slide on that. That's a great question.
Like like sarcoptic mange, and
I
heard that, yes. Yeah, I had a friend who was a veterinary assistant, and she got it too.
And versus color sometimes think about patients, but it can be hyperprotective, and they love the groin. And the kids sometimes they love to go to the pool and they don't change the wet cloths the whole day, and they come with a rash, and you're like, oh. And then because it's a kid, they say, oh, scabies, and it's really.
Yeah. So that's also part of the differential as well, correct? So if you had an immunocompromised patient with this rash, uncontrolled HIV/AIDS, off RT, what would be the most likely etiology? Any thoughts? Well, this is also scabies. Yeah. So, yeah. So basically, a scabies is a mite skin infestation caused by Sarcoptes scabii. It's a clinical diagnosis, and distribution of skin lesions will help you. And it's severely pruritic. These can get super infected with staph or strep, and then, like we said, person-to-person contact more than fomites. And you have to treat all the persons who were in prolonged skin contact with that patient who got scabies. So this is the life cycle, and this is answering her question. These are the usual distribution areas, mainly, groin, buttocks, the wrist surfaces, flexor surfaces, and the popliteal fossa, the extensor surfaces. And then basically the adult female, she does these little burrows, tunnels. She lays her eggs at the end. They hatch, and then they start developing into these nymphs, and it's called molting pouches. And then the male penetrates that molting pouch, and then the cycle starts all over again. The adult does the burrow, and she puts the eggs. So that's why it spreads like that. And then the incubation period for this is 14 days. So some people can take up to 3 to 6 weeks to get symptoms. So, but if there is a reinfestation, the symptom onset is earlier because there is prior sensitization to the mite antigen. And then this slide, not here, this slide, basically, if the patient is immunocompetent, the scabies has that typical distribution. But if they're immunocompromised, you have to screen, or if you have the crusted version, that should be like an alert. I have to screen for HIV, HTLV. It involves the entire skin. It doesn't have that classic pattern. It could be more typical. It's not pruritic, and it can mimic psoriasis. And then it's highly contagious, so you have to, especially in hospital and nursing homes, so you have to isolate that patient. And then and this is called crusted scabies. We don't call it Norwegian scabies anymore because we try to be.
Yeah, I was just gonna say, that's the name of.
Yeah, that one. Yeah. So classically Norwegian scabies, but now we just stick to crusted so that we don't offend anybody. And then that one, the crusted scabies, is treated with ivermectin, and the CDC actually says you should do a combination therapy with topical permethrin, and just regular scabies can be treated with permethrin. And if it fails, you can do ivermectin. So this is actually exactly how I treated the patient, and it worked. So for our third case, I want you to travel with me to Apartado, Colombia. So this is where I was. It's this rural area in Colombia that borders Panama here, and their main source of income and economy there is banana and plantain fields. So that is, it just stretches yards of land, so that when you just first get there, you just see banana fields, more banana fields. So this case, it was a 34-year-old male. He presented to the Colombian Institute of Tropical Medicine, which is where I was rotating at for about 2 or 3 weeks. And he said, I have this skin lesion on the lateral aspect of my right thigh. It's enlarging, it's red, it seems to be draining pus. He said, I think I remember an insect bite. Maybe it was a no-see-um, like Dr. Green said, in that area while he was working in the banana field. And then he was concerned about leishmania because several of his coworkers had skin lesions and leishmania. So he thought it was that. But when we looked at it, it really didn't have the characteristic features of the leishmania. So the skin lesion in leishmania, it usually is ulcerated, and it has these red raised borders, and it's really pretty round, and then it has this associated lymphadenopathy going with it, and it wasn't classically leishmania looking. So my attending at the institute said, no, that's not leishmania. So what is it? Leishmania is not an option there. So any guesses of things we could see? So we already covered pediculosis, scabies, things we could see in tropical, subtropical areas. So so this was actually one of Myiasis case I saw. So what is Myiasis? It's it can happen in travelers. Yes, it's really, I'm glad that I really didn't see anything coming out of there. But yeah, I don't know if I could have forgotten that image. But basically, it's a traveler returning from a tropical jungle this can happen, or vulnerable population living in an endemic area. It's basically the larvae of the human botfly that burrows into the attacked skin, and some people can feel the maggot movement inside. I know. And then it's kind of the most common clinical, he didn't say any of that. So this is the most common clinical manifestation is furuncular. So it's basically like a cutaneous or subcutaneous nodule with a central punctum. And then it starts to drain, and it resembles a boil or furuncle. And then just a clinical diagnosis as well. There are other plenty of, flies. And just depending on what region of the world you're in, there's other forms of it. Like you have a kind of a wound cavitary form. And the wound cavitary tend to be more invasive. So you definitely have to be, a little bit more aggressive there. But just based on where we were at, which is South America, it's a New World botfly. And the manifestation, I thought he probably had this one. It was caused by dermatobia. For example, the Cochleomya, Chrysomya wolfaria, these are all invasive species, and surgical removal is indicated for invasive species. But first line, you actually occlude that punctum that you see, because the larva will kind of resurface to get some air, to see some fresh air, and come back down. And so you want to prevent the gas exchange. So you put some Vaseline or fingernail polish or some occlusive dressing, and then that'll cause the larva to migrate, and then you manually extract it. Thankfully, I didn't have to do any of that. But sometimes the larva asphyxiates in there, and then it has to be surgically removed. And you know that if it doesn't emerge in 24 hours. Yeah.
Like in India, when we had like diabetic foot extending to the leg, they get infested with maggots. So they
Correct.
put the med students in charge of removing. So everyone.
Oh, wow.
And all of them fall off. And then we pick them up.
Oh, wow. You guys have it good, you see? Yeah. Okay. So, super infection does not occur. Removal is sufficient. And I think, did you see any of this Tungiasis over there in India? In the feet? Okay, yeah. You only know what you know. That's what Dr. Grace say. So yeah, I've never seen the case of this, but it occurs. It can occur in returning travelers and in impoverished communities in developing countries. And a traveler who lives in a developed nation, you come back, parasite burden is minimal, and you just get surgical care for this. But this, and it's not the same as myiasis. Is basically a gravid female geography Tunga penetrans, hence the name, penetrates the bare skin, feet or heels or toenail or interdigital web spaces, and then they do the blood feeding swell. She's pregnant, so she swells like, 2,000 times her size, and then she starts just laying and incubating her eggs there for a 3-week period, and then she dies, and the carcass is there. So this is also a clinical diagnosis, but in these developing tropical nations, it is a very recurrent infestation of the feet, high parasite burden, and it can get so bad that you can have even auto amputation in the feet. Okay. So the treatment is what she said. You extract all of the fleas with a needle or whatever you can use to get to it. And there's no therapeutic options for this besides surgical extraction. And then you have to administer the tetanus prophylaxis in this case, because there have been cases of Clostridium tetani related to Tungiasis, not Myiasis yet. And then you do treat super infection here in this case. So the prevention is basically not walking on the bare ground, because that's the preferred egg-laying surface for the flies, not sitting naked on it, or you have to wear protective long sleeve clothing. Some people can spray it with DEET or solution, sleeping in a raised bed or cot, cementing the floors, getting rid of animal carcasses, because those are the breeding grounds for the flies. And then if you get a Cochleomya case here in the United States, you have to call the public health department, because this is a livestock threat. And then case number 4, and I'll be a little bit brief with this one. This is actually a case I saw at the VA when I was rotating at the ID clinic as a first-year fellow, I think my second month. So where you guys are sitting at. So we do see cool cases at the VA too. And then this patient, basically, he had a motor vehicle accident. The right foot went underneath the motorcycle. So he had some trauma injury to it. He got treated with some antibiotic, and podiatry saw him, and that antibiotic didn't work. He had a wound infection, cellulitis, and then he got, treated with some broad spectrum IV antibiotics, transitioned to PO, and the blood cultures and the deep tissue culture was negative. I know you're wondering, why are we consulting IV then? But then he went to the podiatry clinic, and the wounds were healing well. There wasn't any symptom of infection. He was doing good, and they still placed an ID consult. So why? So basically, it read, patient with superficial linear tortuous lesion to the dorsal right foot, likely this. I'm not going to tell you the diagnosis. Please evaluate and treat. And so this is kind of what I saw. I'm like, let me see your foot. And this is what I saw at first glance. And I'm like, I don't see what they're seeing. So I kept, I was like, okay, let's get some social history. So he was born and raised in Memphis, lived in Puerto Rico, traveled abroad to Europe. He resided in Brooksville and had a cat. He was disabled, retired, divorced, sexually active, but didn't go much into detail, and no other kind of significant exposures. So it's very faint, but I think you may be able to appreciate it. This is what the podiatrist wanted me to evaluate. Any idea of what this is? Cutaneous larva migrans. So this is what the podiatrist said. This is cutaneous larva migrans. I just want you to treat them. That's basically what happened. So this is kind of a better picture, but that wasn't the patient. The other one was the patient's. So this is basically just the cutaneous penetration by the larva of a dog or cat hookworm, ancylostoma or Uncinaria. And it's very characteristic. You probably get a picture of this on the board. It's just raised, red, and pruritic serpiginous and a migratory tract, and it can occur in any body part that contacts the ground or the contaminated surface, and it's a clinical diagnosis as well, no serology available. And that's basically the life cycle. The dog or cat, the eggs are in the feces, the hatch into larva, and then the human skin comes in contact with the larva, and that's how it happens. Or then it goes back to the dog and cat. And then the primary regimen is albendazole, ivermectin. I think we treated this patient with ivermectin, and he did well. I read a podiatry follow-up, and it's had resolved. And then there's no alternative treatment. So basically, cryo is obsolete. You just have to repeat one of the primary regimens if there's treatment failure. And then you advise travelers to tropical areas to wear closed shoes or, do a protective mat or towel, especially if they're sand or soil contact, so that you can prevent this. And then case number 5, this was anecdotal, a friend of my mom's. 26-year-old male, visits New Jersey with his family. His sister's graduating from vet school, develops multiple pruritic erythematous papules in a trunk linear pattern after staying in a hotel in New York City. So pest control confirms the presence of this bug on the left. So what is this one? And it's the only one left. Okay, there we go. Yes. So bedbugs, basically the adult, it's a cymic species, and based on the area they're at, it's different species. And then you have adult, and then 5 nymphal stages to become an adult. And each nymphal stage, you go from one nymphal stage to another with a blood meal. Think of it as a level up, and basically, that's how the cycle is. So that's why you'll have it in a linear pattern, because they have, and you'll hear the term breakfast, lunch, dinner, because that relates to the blood meals that they take in so that they can do their development. Spontaneous resolution, you don't have to treat it. You can do supportive care, antihistamines, a corticosteroid. And basically you have the way you eradicate it is, pest control has to come, identify, put the insecticides, treat it and everything. And that's it. Thank you for your attention. Any questions, comments? This is a picture from Puerto Rico from the last time I went.